Hello, I'm Mike Kontos, the CardioSource Editor-in-Chief of the Cardiac Biomarkers community. Heart failure is a common problem with an estimated 3 million hospital admissions each year, the vast majority of whom present through the emergency department. Estimated costs of hospitalization are over $20 billion a year. Outcomes in hospitalized heart failure patients are heterogeneous, with a wide range of 30-day mortality ranging from a low of 2% up to 7%. The 30-day readmission rate is 2 to 3 times that, and in fact, heart failure has the highest readmission rate of any discharge diagnosis. Despite its importance, there is little evidence-based information on the appropriate acute management of heart failure patients presenting to the emergency department. Of the 18 Class 1 recommendations for acute heart failure treatment, only one has Level 1 of Evidence A data. Instead, the majority of therapies are level of Evidence C, based on expert opinion alone. To address this, the National Heart, Lung, and Blood Institute sponsored a working group on emergency department management of acute heart failure, the results of which were published in the July 28th issue of the Journal of the American College of Cardiology. Major strategies that were discussed included the need for early risk stratification to distinguish between low-risk patients who could be discharged and returned for an outpatient appointment or be admitted to an observation unit versus higher-risk patients who require hospital admission to an intensive care unit. Another strategy was funding investigations leading to better understanding of the pathophysiologic contributions and therapeutic responses resulting in early cardiac and non-cardiac injuries. Recommended actions included design and conduct of ED-based clinical trials focused on emergency heart failure management, which would include prospective testing of both existing and new interventions. One of the research priorities for funding was recommended included biomarkers for early diagnosis and management. There is a critical need for newer methods of diagnosis and risk stratification. For example, diagnosis and risk stratifications of acute heart failure syndrome currently consist of the medical history, physical exam, and routine lab testing. However, acute heart failure remains a challenging diagnosis because the predominant symptom, shortness of breath, is relatively nonspecific. The physical exam is insensitive, and chest X-ray findings are unreliable. Therefore, newer therapies are needed. The only biomarker in routine use for diagnosis of heart failure are the natriuretic peptides. Although the natriuretic peptides BNP and NT-proBNP are useful and cost-effective, they have limitations. Many non-heart failure cardiac conditions, such as MI and left ventricular hypertrophy, can lead to natriuretic peptide elevations. Thus, although a low NP rules out acute heart failure, a rule-in diagnosis is complicated by an indeterminate gray zone. Other confounders include that levels are increased in renal dysfunction, but may be reduced in obesity. Despite these limitations, natriuretic peptides are strongly prognostic of future adverse events. The Red Hot trial showed that 90-day event rate in patients admitted who had a BNP above and below 200 picograms per milliliter was more than threefold different at 9% and 29%. Therefore, if validated, the natriuretic peptides could represent a safe and cost-effective strategy guiding emergency department disposition. There are a number of other markers that have been evaluated in the acute heart failure setting that have shown promise. These include mid-regional pro-atrial NP, adrenomedulin, copeptin, and ST2. In addition, the infection marker procalcitonin might help differentiate acute heart failure from pneumonia. Additional validation of their prognostic value will be necessary before direct application in the emergency department. Another significant complication in acute heart failure management is the cardiorenal syndrome, which is a potent mortality predictor. Although creatinine is traditionally used to assess renal function, statin C appears to be more accurate for this. Sensitive early markers of acute kidney injury, such as NGAL, kidney injury molecule 1, and interleukin-1 might also have clinical value. Ultimately, a panel of markers for cardiac stress, infection, acute kidney injury, and necrosis might be the most useful for risk stratification, assessing both prognosis and guiding management. It is hoped that the results of this initiative will lead to investigations that will substantially improve our treatment for this high-risk patient population.